Hi everyone. Today's lecture topic is positioning in neurosurgery, and we're going to cover it under the following headings. So, we'll be discussing a few basic tenets of positioning in neurosurgery and what actually happens and the things we need to be concerned about. And then a few basic positions: the supine, the lateral, the prone, and the sitting. So, coming to the basics of positioning in neurosurgery, an ideal position for any patient when you're operating on them should provide maximum access to the pathology for the surgeon while still providing maximum access to the patient for the anesthetist, but also including these two, the position should also put the patient at least risk of injury. So always remember a few things when it comes to any position. You must ensure that the patient is secure to the table and there's no chance of the patient falling down. Absolutely avoid pressure injuries. So make sure that pressure points are padded. Avoid any sort of pressure ulcers and peripheral nerve injuries that may develop because of your positioning. And always avoid the risk of increased venous pressure by avoiding extreme turning of the head so as to prevent veins from collapsing, and elevate the head above the level of the heart. Okay, so let's understand exactly how different positions will alter the physiology of blood supply to the brain and what we need to do to really make it work. So basically, when the patient is in the neutral position, there's no rotation, there's no flexion, there's no extension. That is when they get the optimum amount of blood flow. Any deviation from this neutral position leads to altered physiology. Now, this alteration of physiology could affect the mean arterial pressure, the venous pressure, the pressure on the CSF, the intracranial pressure, or the cerebral perfusion pressure. Now, the CSF pressure is more or less usually going to remain constant, and positioning mostly ends up affecting your arterial and venous pressure. And it affects your venous pressure a lot more than it would affect arterial pressure. Now, arterial pressure is not really affected by a basic position as such, but some rotation or some flexion extension can affect arterial position. Venous pressure, on the other hand, can be affected by a basic position. It is the same in a supine or a lateral position, but putting the patient in a prone position, on the other hand, would increase the venous pressure by at least 2 millimeters of mercury. Now, if when the patient is in the neutral position, we know that the physiology is optimal. Any change from that, physiology is going to change. So tilt angle is basically the angle between the patient's body and the horizontal. Positive tilt angle is achieved by elevating the head end of the bed. And whenever we do that, both the arterial pressures and the venous pressures in the head will decrease. And that is with positive tilt angle. Positive tilt angle is when the head is going up, and with that, arterial and venous pressures will decrease. But venous pressure is a little bit more complicated. Now, arterial pressure can just be estimated using this formula here, which tells us as your tilt angle, which is over here, increases, your arterial pressure will decrease. But venous pressure doesn't exactly work like this. What happens as you're elevating the head end, there will be a certain point at which the internal jugular vein will finally collapse. When that happens, the pressure in the venous system in the head gets separated from the rest of the body. So any further increase in height beyond that, the venous pressure again starts to rise instead of falling down further. So you can actually model it with this really complicated equation, but the only thing to remember is as your head is rising up, there will be a certain point where the IJV collapses. Till that point, the venous pressures will be decreasing, and then it will be further increasing from that point onwards. So as we can see over here, this is the change that happens in cerebral perfusion pressure and intracranial pressure with changes in head elevation. So this is neutral. As you elevate the head slightly, because arterial pressures and venous pressures both are falling, but your venous pressure falls a lot more than the arterial pressure does, ICV will fall. But because venous pressure is falling a lot more than arterial pressure, cerebral perfusion pressure will rise. On the other hand, the point at which the IJV collapses, the venous pressure again starts rising. So your fall in ICP decreases and your cerebral perfusion pressure, instead of going up, now starts to fall down. On the other hand, if you put the head end down, your ICP is going to rise and your cerebral perfusion pressure is going to fall. Okay, so that was about the elevation of the head, but there are also other movements that we can do with the head. There's flexion of the head, extension, lateral rotation, and axial rotation. Now, any of these movements are going to alter the dynamics of blood flow. The normal neck motions will not affect arterial pressure as much, but they can affect venous pressure and lead to changes in ICP and CPP. Now, there are these complicated equations that we can use to figure out what change would happen with these positions, but we don't really need to go into that. An important thing to remember is as you rotate the head further and further, the veins will collapse further and further, and your venous pressure will go on increasing. Any combination of flexion or extension with lateral flexion or rotation will actually help to decrease the influence of this second motion, that is lateral flexion or rotation. Whenever you both flex the neck and rotate the neck, you get the largest increase in venous pressure and ICP. So we can understand this with this picture over here. As we can see, when the position is neutral, when there's absolutely no change in the neck or the head position, that is when you have the best physiology, you have the highest cerebral perfusion pressure and the lowest ICP. Any alteration from this, you have a change in the cerebral perfusion pressure for the worse and also in the ICP as such that it increases. So as we can see from a neutral position, if we extend the head, also ICP will increase and cerebral perfusion pressure will fall. If we flex the head also, ICP will further increase and cerebral perfusion pressure will fall further. The worst situation where the ICP is the highest and the cerebral perfusion pressure is the lowest is when the head is both flexed and rotated. Okay, so that was about the basics of positioning and a little bit about the physiology. Let's get into how to position a patient itself. So an important aspect to understand here is how will we fix the head for any type of neurosurgery when we have positioned the patient. So the most common fixation device that is going to be available these days is the Mayfield Clamp. And this is how the Mayfield Clamp is designed. It's basically a 3-point fixation device. There are 3 points which are fixed to the skull. So there's one side where you have a single pin, and then there's one side with a swivel over here, as you can see. So this is the swivel, right, which has 2 pins. So there's one pin here and one pin here. So this swivel rotates. It can rotate throughout the range of 360 degree, right? And there is this lock over here, this one, which stops it from rotating. On the other hand, this is the side where you have the single pin, and you have this screw mechanism over here, which if you turn, will dig this pin into the skull. This here is another screw head which can be pulled out. Once you pull it out, this arm of the one side pin can be moved inside or outwards. This part over here is attachment to the rest of the frame, right? So another important thing which is present on this screw where the single side pin is attached is, on the outside of the screw there's a screw head. Once you rotate this screw and dig the pin into the skull, the screw head will start popping out. Once it starts popping out, you will on the screw head and its shaft, you will start seeing these lines, where every line indicates that you're applying about 20 pounds of pressure to the skull. In adults, we usually tend to apply 60 pounds of pressure overall, so we want to see 3 lines at least when we are fixing the screw to the skull. So here we can see some pictures and examples of how the Mayfield clamp is applied. So this is one of the ways you can apply it. You can apply it upside down when the patient is supine and then turn it around, for example, after you've positioned the patient. This here shows pictures of application of the Mayfield clamp to the skull. Here, as you can see, it has been positioned below the superior temporal line. That's something we usually want to avoid. We don't want to put a pin below the superior temporal line. So where can we place a pin? So one of the easier ways to remember where to place a pin is place it along the headband area, the area where you would apply a headband. But it's not as simple as that. There are areas within the headband you want to avoid. So you want to avoid this region where the frontal sinus would be present. And you want to avoid the region below the superior temporal line, because usually the bone is quite thin over here and there's a lot of muscle, so you want to avoid that. There might also be arteries running here that you want to avoid. And another important aspect to understand when you're applying pins is something known as the equator of the skull. Now the equator of the skull is not just the point at which the cranium splits in, for example, can be divided into two. So this would not be the equator of the skull. So in the next 2 or 3 slides we'll see what exactly we mean by the equator of the skull. The frame of the clamp should always be dependent, so we'll see in the next slide how that happens. You want to avoid areas of skin blood supply, as we saw over here, the areas of thin bones, the areas of the air sinuses, and the areas even of the venous sinuses. Do not put it over the areas of the transverse sinus or the sigmoid sinus, or even the superior sagittal sinus. You also want to remember that sometimes patients would have undergone previous craniotomies or shunts, and you want to keep track of these when you're applying pins and make sure you avoid these areas. Right, so other few basic rules which might apply when you are putting the pins is that the 2-pin swivel always should be placed first onto the skull, and then using this lever mechanism over here, the single pin can be pushed into the skull after that. So the equator of the skull, as we have discussed in the previous slide, is basically a plane which is parallel to the floor, passing through the skull, through the middle of the skull. And this changes from position to position. For example, in the supine neutral position, this plane is going to be parallel to the floor, and as we can see over here, it passes in this plane. But in this plane, when the patient's head has been turned by 90 degrees, this plane parallel to the floor passes along the superior sagittal sinus. So the equator of the skull really depends on what is the head position like, but should always be parallel to the floor. Now a rule with that equator is that 2 of the 3 pins should be placed below the equator of the skull. So as we can see over here, 1 pin and 1 pin has been placed below the equator of the skull, and the other pin should be placed above the equator. Now the 2 pins below the equator of the skull basically act to prevent downward displacement of the skull, and 1 pin which is above will act to prevent upward displacement in case that might happen. Right, so even in this example, as we can see over here, 2 pins have been placed below the equator and 1 above. It is also possible that you can keep this 2 pins where they are and place this 1 pin over here also, but that is not what we want. We want to place the other pin again below the equator, so that at least 2 pins are below the equator. Another thing we would like to do is that when it comes to the 2-pin swivel on one side, the pin which is lower down should be placed more inside. It should be located further inward than the pin which is higher up. This ensures that whenever you are applying pressure, the skull will be pushed into the pins. On the other hand, if for example, if the pins were such that the upper pin is here and the lower pin is here, where the upper pin ends up being more inside and the lower pin ends up being more outside. In this system, for example, when you apply pressure, the pins will tend to slip. So you want the pin which is lower down to be more towards the inside, and the pin which is higher up to be more towards the outside. Right, before you apply the pins, always make sure that the clamp is completely working, it's free, and the single pin side is moving freely, and the other side where the swivel is present, it's rotating freely as well. Now if the patient is anything above 10 years of age, you can go ahead and use adult pins with 60 pounds of pressure. For those of 5 to 10 years of age, again you can use adult pins. Adult pins are longer pins and they will end up digging further into the skull. So you have to use a little bit lesser pressure with 5 to 10 years of age. You can use 31 to 50 pounds of pressure. Below 5 years of age, we would like to use only pediatric pins with even lesser pressure. At 4 to 5 years, you can use 21 to 40 pounds. That will be anywhere between 1 and 2 lines. For those 3 to 4 years, only 20 pounds. And for those 2 to 3 years, 10 to 20 pounds using pediatric pins. Below the age of 20 years, just avoid any sort of pin fixation. So this is a video demonstrating how we apply pins usually. So as we can see over here, first we apply the 2-pin side with the swivel onto the skull, and then we rotate it because this entire system easily rotates to decide where we want to apply the single pin. and then we move it inwards towards the skull. And then both the sides have to be held tightly and pushed together until you hear about 3 clicking sounds. Usually you would like to hear 3 clicking sounds, that means it is secured in place. But sometimes you might not be able to hear that because it does take a lot of pressure, so even 1 or 2 clicking sounds are okay. Following which the screw head is turned in until you are able to reach it, since this is an adult patient, about 60 pounds of pressure. So this is the clamp attachment system which will go and be fixed into this clamp. Once you have reached the 60 pounds, now you would fix this and lock it on the rotation side to make sure that the clamp cannot move around anymore. Right, so this is an example of frame fixation for a patient, and it is possible to fix a frame this way, but there are some changes which I can suggest over here which would make this a little bit better. So as we can see over here, the equator of the skull in this patient would actually be here because this is the plane parallel to the floor. So you want two of the pins to be below and 1 pin to be above, and it is correct, 2 pins are below the equator and 1 pin is above the equator. But a much better system of arranging this clamp would be that this frame of the clamp should be dependent, because so instead of being towards the side, it would be better if the frame was applied like this. So you would want 1 pin to be above the equator, 1 pin to be below the equator, and the 3rd pin again to be below the equator, and the frame of the clamp is dependent, so the head does not tend to move down as much. Right, so that's about head fixation. Now coming into actual positioning, right? So there are a few basic rules we want to follow for any positioning. There are 2 very important things. It is the job of the surgeon to ensure that there is safety of the head and the neck, and the anesthetist must ensure that there is safety of the endotracheal tube and invasive monitors when positioning. It is preferable for at least 1 person to be standing on either side of the patient for positioning, apart from the surgeon and the anesthetist. If it is a lateral or a prone position, it is better at least there are 2 people standing on either side. Once you have positioned, a few important rules that we have already discussed are: the head end should lie above the level of the heart for cranial surgeries. The head should sufficiently be outside the edge of the table, such that the shoulders are lying at the edge of the table, and the pressure points should be adequately padded. Right, so let's now discuss a few supine positions and how to position a patient in the supine position. When it comes to supine positions, a few things are important, particularly with supine position, that is neck rotation. So it's important to keep in mind, especially when you're going to position a patient supine, as to how much rotation we need to give the head for particularly different surgeries. Apart from that, surgical perspectives of natural anatomic corridors, like for example, if you want to go through a Transilvan approach, as to what would be the position of the head for that. How you can achieve gravity assisted retraction, for example, even in the supine position. And you want to position in a way that the entire system is quite ergonomic for you. Now, so the important thing here is head, neck and body mechanics. It is possible to achieve any level of rotation by combining axial rotation of the skull along with rotation of the body. So it is possible that you can turn the entire head by 90 degrees and achieve a 90-degree rotation. Other thing you could do is just turn the head by 45 degrees and turn the body by 45 degrees and achieve a 90-degree rotation. So that is also possible. So instead of neck rotation, angulation can be increased by body rotation as well. So you can create an oblique position like this using shoulder rolls. For a patient who has degenerative or atherosclerotic disease, that is degenerative spine disease, or atherosclerotic vascular disease, we don't want to rotate their neck as much. Their cervical spine and their vessels will not allow for it. So in those patients, you want to avoid more than 45 to 60 degrees of rotation and avoid any amount of hyperflexion. As a general rule, at least 2 finger breadths of space in the thyromental space is required. Now, the most common craniotomy that we would usually be doing in the supine position is a Tiranol approach. There have been 2 different positions described for the tenonal approach. The first one was described by Yasser Gill, and that is usually what is commonly followed. In that, for the trans-Sylvian tenonal approach, we would rotate the neck by 30 degrees to the opposite side, elevate the head, and then extend the neck by 20 degrees, so that the malar eminence becomes the highest point. Rotor, on the other hand, suggested that you could decrease this rotation to only about 20 degrees and further do a lateral flexion, or since on the side of surgery it would be considered a lateral extension. This opens up the space a little bit more and also helps to make the frontal lobe fall away from the Sylvian fissure. So with tenonal approach, a very commonly asked question is how much rotation should one give? That really depends on the area you're trying to access. So about 20 to 30 degrees usually will align the Sylvian fissure parallel to the surgeon's view and make a trans-Sylvian dissection much easier. Any more rotation than this, then the temporal lobe tends to fall onto the frontal lobe. So that makes the Sylvian dissection a lot more difficult. Further rotation will also hinder access to deeper parts of Sylvian fissure. So a general rule is the closer a pathology is to the midline, the lesser amount of rotation you want. Okay, so you can imagine it like this. For example, if this is the skull, this is the frontal bone, this is the lesser wing of the sphenoid, this is the greater wing of the sphenoid. So this would be the ACF base, this is the MCF base. Okay, now for example, if you are operating from here through a trans-Sylvian approach, if you don't have any rotation, if it is at 10 to 15 degrees, you'll be able to see the midline structures. Now for example, if you rotate this head, the deeper part of the Sylvian fissure moves away from you, and more of the temporal lobe, for example, is in your view. So this is the ACF base, this is the MCF base, this is the midline structures over here. So as you can see, if you're trying to see from the same space, the midline structures become even more difficult to see. This deeper part of Sylvian fissure becomes even more difficult to access, and the structure which will be obstructing your view. So the more closer to midline of structure is, the lesser rotation you want. So usually for anterior communicating artery aneurysms, for example, we would only give about a 10 to 15 degree of rotation, while on the other hand, for MC aneurysms, we can go ahead and give a 45 degree rotation of the head. Now supine positions overall are very simple positions. The patient is already supine before positioning even starts, so there's not really much to do. You just have to pull the patient up out of the table, so the head is out of the table, and rotate and extend or flex the neck as you want, and then just fix it into place. There are fewer points of concern than any other positioning, but there are a few important things to remember. Some of these are: avoid excessive neck rotation, and ensure that if you are planning to rotate the body after positioning, after craniotomy, that there is enough stability. So even in a supine position, you want to make sure there are at least two straps, even if you are not going to rotate, because you don't know intraoperatively if you'll require to rotate the patient or not. Now, a few examples of supine positions. Some of the most commonly done craniotomies in supine positions. This is a bifrontal craniotomy. The patient will be supine, as we can see over here. Usually the head is going to be neutral in the axial plane. There's not going to be any axial rotation as such. Now depending on where you want to go, if you want to go into the ACF base or you want to go into the frontal convexity, you will decide what is the amount of flexion or extension you want. Now if you want to go into the ACF base, as probably is being done over here, you want the maximum amount of extension possible. Okay, you just have to imagine that where is the ACF base, and when you're operating, what will be your angle. So extension accordingly. On the other hand, if you're going to the frontal convexity, you probably keep the patient neutral in the sagittal plane, or just have a very limited amount of extension. On the other hand, for a parasagittal craniotomy, again the patient would be in a supine position. This is a parasagittal craniotomy in the anterior half of the superior sagittal sinus, not the posterior half. So the head will be again in the neutral plane. In the axial plane, it will be neutral. There will be no lateral rotation. But in the sagittal plane, for example, if you want to go into and operate on a colloid cyst, which would be somewhere over here, you would require a slight amount of flexion. So you want to mark out your craniotomy first and then flex the head slightly such that the area of the craniotomy points directly towards you. Okay, so this is one of the most common craniotomies which we will end up doing. So this is the frontotemporal craniotomy. So this, as we can see over here, is also again in the supine position, but as compared to the previous two surgeries, here there will be some amount of rotation. Now in the axial plane, we rotate according to the pathology as we've already discussed. If you're going to rotate up to 45 degrees, you can do it without elevating the ipsilateral torso, and there's no need to put a pillow under the ipsilateral shoulder. But any rotation beyond 45 degrees, you want to put a pillow or some sort of a shoulder pad below the ipsilateral torso. In the sagittal plane, you're going to have to give some extension for these frontotemporal craniotomies so that the malar eminence over here ends up becoming the highest point. There are some other surgeries, for example, like the VP shunt also, which will be done in the supine position. So for this position, the head ends up remaining on the OT table. So if this is the OT table, a few important things for a VP shunt position. So basically, if this is the right side and you're operating on the right side, you're putting a shunt on the right side. So you want the patient to be positioned such that they are as much towards the right side of the table as possible. Okay, so the arm over here, the right arm, should touch the edge of the table over here. So take them as far to the right side as possible. The second thing is the head will be rotated as much as possible to the opposite side. So usually ends up being rotated by about 90 degrees. To do that, you'll have to place an ipsilateral shoulder roll under this shoulder, and then this head is placed onto a donut. So these are the important positioning requirements for a VP shunt. Take the patient towards the side of surgery. Okay, turn the head to the opposite side by 90 degrees. Place a shoulder roll under the ipsilateral shoulder, and place the head on the donut. Right. So some of the most common surgeries we'll end up doing as residents would be surgeries for chronic aesthetic trauma. Almost similar positions. The patient will be supine, pulled up onto a horseshoe, followed by rotation to the opposite side by about 45 degrees only. There's no need to rotate any further than that. A lot of these patients are quite old and probably might not tolerate a lot of neck rotation. Right, so it is important to check this amount of rotation that is possible before anesthesia so you can know how much you can rotate the neck. If the neck range of motion is poor, you can just rotate the torso and achieve that neck range of motion instead. Another common surgery that we'll end up doing is trauma surgeries, where the most commonly done craniotomy is a frontotemporal parallel craniotomy. So for that also, again, the patient will be supine. The head can be placed on a horseshoe, which is most commonly what is done, but it also can be placed on pins. Placing the head on a horseshoe is going to be faster, which is good for trauma. During surgery, you can rotate the head as much as you want and turn it back and forth. And if there's a fracture, then you probably want to avoid placing pins because you don't know where the fractures might be. But there are advantages even to placing pins in patients of trauma. There's a lot of times when during trauma surgery, because it has to be done quickly, we're not able to control the amount the neck rotates. So in case we want to prevent rotation beyond 45 degrees, we might want to place the patient's head on pins. Because it is on pins, there is always going to be an amount of counter pressure by the pins when you're doing a craniotomy, so it does make the craniotomy a bit easier to do. For an FTP craniotomy or frontotemporal parallel craniotomy, keep it at 45 degrees rotation only. There's a tendency for people to rotate the neck quite a bit, maybe 50, 60, even 90 degrees, but avoid excessive rotation that only adds the amount of venous bleeding that is going to happen during your surgery. Always, if you're going to rotate by 45 degrees, place an ipsilateral shoulder roll. And make sure that if you decide to rotate the neck, that the cervical spine is stable. Okay, another commonly done surgery is a transnasal endoscopic surgery, and the positioning for that is a little bit different compared to the other positions. Patient is again supine. The head can be placed on a horseshoe or a pin. Right? in the axial plane, we're not really going to rotate the neck. There's no amount of rotation that is required. What is done usually is a contralateral head tilt. So the head should be tilted to the opposite side. So this surgeon over here is able to introduce the endoscope into this patient's nose over here. In the sagittal plane, you want flexion or extension depending on the area you want to operate. Now, if you're operating on the sella itself, usually you keep the patient's head neutral in the sagittal plane such that the dorsum of the nose is parallel to the floor. If you want to go more anteriorly, like towards the tuberculum sella or towards the cribriform plate, you would want to extend the head. If you want to go more posteriorly, you would want to flex the head. Right. Another commonly done surgery is the anterior cervical approaches. The anterior cervical approaches also require a supine position. In these cases, for example, if you're doing an anterior cervical discectomy or fusion, you're going to want to keep the head on the OT table itself. It is also possible to put it on a horseshoe, but you will get more stability if it is on the OT table. You can put an extension board and leave it on the OT table on a donut. And Gardner's belt traction usually has to be placed. In the axial plane, it should be neutral, and in the sagittal plane, you want to achieve the maximum allowable extension by placing a roll under the scapula. Right. So that is all about the supine position. So let's discuss a little bit about the more complicated positions like the lateral position. Now the lateral position is also known as the lateral decubitus position. Now what does decubitus actually mean? The side which is down is known as the decubitus side. For a right lateral position would be that the right side is down. Right. So in lateral position, a problem which can usually arise is that between both the arms there can be a significant discrepancy in measurement of blood pressure, even up to 32 millimeters of mercury. Other problems that can arise are that when you shift a patient to lateral position, the mediastinum is going to shift towards the downward side, which will cause the heart to rotate. This will decrease the venous return and decrease the cardiac output. The lowest cardiac output and the lowest MAP would arise in the right lateral decubitus. Apart from that, there also will be some amount of ventilation perfusion mismatch. The upside lung will be well ventilated, but the downside lung will not be. But the upside lung is well ventilated but still poorly perfused. So there is some ventilation perfusion mismatch which happens with lateral positions. Apart from that, both the sides brachial plexus can be at risk. The dependent brachial plexus can be at risk because of compression. So you want to use an axillary roll, basically any soft structure placed under the axilla to prevent compression. The non-dependent brachial plexus can also be at risk because you will pull the ipsilateral arm. So when you're trying to get some space when you're operating. So when you do that, it is possible because of stretching that the non-dependent brachial plexus can also be at risk. So you have to carefully tape the shoulder. You also always want to place a pulse oximeter on the dependent arm, because on the non-dependent arm it will give a false low reading. There can be a few complications that arise because of lateral positioning. Pressure injuries can happen on the dependent areas involving the skin, the soft tissues and the ligaments. Backaches can happen, but they're still lesser than the supine or the prone position. Damage to the brachial plexus, either contralateral or ipsilateral, can happen. And hypotension, as we have discussed previously. Now, what are the steps for turning a patient into a lateral position? So there is an important sequence of events to be followed. There should be one person who must coordinate the entire sequence of events, either the surgeon or the anesthetist. Right? So remember, for lateral position, we want at least two people to be standing on either side of the patient. Now, once the patient is in a supine position, you want to hold the head and the endotracheal tube and make sure that nothing slips out. And the patient's body is going to be rotated about 90 degrees while keeping the head and the body aligned. Following which the patient is shifted upwards such that the head and then also the contralateral arm is taken over the table edge. Following which the patient's torso is lifted up and a pillow is placed under the contralateral axilla. This is to avoid compression of the brachial plexus. Then you're going to secure the patient in this position with padding and straps, and make sure that the pressure points are adequately padded. These are some examples. It is possible to do a to do multiple different approaches with this positioning. So some of the common ones are going to be, for example, a temporal craniotomy. So here you can do it either in a supine position with a significant amount of head turn. So you can do a head turn of 20 degrees. You can even do a head turn of 45 degrees with a body turn of about 45 degrees as well. Or you can put the patient in a lateral position itself. Here the midline will be at 90 degrees to the floor. But in the axial plane and the sagittal plane, the patient's head will be neutral. You can improve exposure by putting the head in a slight lateral flexion over here. So this is an example of a temporal craniotomy and the position for that. So as you can see over here, there's no cervical flexion, there's no rotation of the head. And here we have not already given any lateral flexion. These are what is being done with the rest of the body. So as you can see over here, there's adequate padding of all the pressure points. Okay, so the lower limb has been flexed and the upper limb has been the lower leg has been flexed and the upper leg has been kept extended. Still mildly flexed at the knee to prevent any traction injuries. The contralateral arm is over here on this arm board, and there's an axillary pillow under this axilla to prevent any compression injuries. The ipsilateral arm is above here and it is taped into position, but we make sure that there's not a lot of traction on the arm so as to prevent any stretch injuries to the brachial plexus. All these pillows over here are used to make sure that the patient does not fall. A very commonly done approach is going to be the retrosigmoid approach, and very important three maneuvers required to achieve this position. So once you have positioned the patient in the lateral position, as you have seen in the previous slide, you're going to do three maneuvers of the head. One is going to be cervical flexion. The second is going to be lateral flexion. And the third is going to be rotation. So this will make the mastoid over here the highest point. So this is how to achieve an ideal position for retrosigmoid approaches. Right. Now coming to the prone positions. The prone position, when it comes to positioning, is definitely one of the most complicated positions because it has a significant hemodynamic component to it. So it significantly affects the cardiovascular system and the cardiac index will reduce. And this happens because of reduced venous return, because of a significant amount of pressure that is now placed onto the abdomen. So this is going to decrease venous return. There's also going to be reduced left ventricular compliance because of increased intrathoracic pressure. So if there's any amount of increasing abdominal pressure in prone positions, it will further worsen in venous return and increase the risk of venous bleeding when you're operating, but also increase the risk of DVT. Apart from that, because the lungs are not expanding that well, there's also going to be some ventilation perfusion mismatch even in the prone position also. A very important thing when it comes to prone positioning is absolutely avoid pressure on the abdomen. So these pillows over here or rests have been placed on the torso and on the pelvis, but we have to make sure that there's no pressure on the abdomen. So a few important things when you are positioning the patient in a prone position. It is a neurosurgeon's job to make sure that the endotracheal tube does not dislodge. So when you're turning the head, make sure you're holding the tube between two fingers. And when you're turning the head, make sure that you're keeping the axis of the spine neutral. So turn the head in the same speed and direction as the body. If you have any concerns about spine instability or you're operating for spine instability, you can use a collar, a hard cervical collar, to limit some spine motion. Once you have positioned the patient prone, there are multiple places where you can keep the head. For cranial and cervical spine approaches, we can put it either in a Mayfield clamp or a horseshoe. But for lower spine approaches, we want to put it onto a gel pad or a donut. There are a few variations of the prone position which are important. So this example is out of a concord position. So in a concord position, instead of operating from the top end of the head, usually the surgeon operates from the lateral aspect, from the side. A concord position can be achieved by first elevating the head end and then putting the neck in flexion. That's the basic idea. Elevate the head end and put the neck in flexion to achieve the concord position. Another variation is the Superman position, where the arms are basically pushed anteriorly and placed on these arm boards. This is usually for patients where we're operating on the mid dorsal and the lower spine regions. This is to prevent the arms from being on the side when we're doing radiography to visualize these areas. Right, so with prone positions, a lot of complications can arise. You can drop the patient during turning, and you definitely don't want to do that. You can also lose airway, vascular lines, and catheters when you're turning the patient. You can sometimes have some injuries developing towards the central nervous system because of either arterial occlusion, cervical spine injury, or venous occlusion. A venous air embolism can happen in the prone position also, and because of a significant amount of flexion in some of these positions, hyperflexion injuries to the cervical spine can also happen. Apart from that, you can also develop brachial plexus damage, pressure injuries, macroglossia, and sometimes even a post-operative visual loss. Now this happens in about 0.2% of spine surgeries, and most commonly it occurs because of an ischemic optic neuropathy, but can even arise because of central retinal artery occlusion. So how would you turn the patient prone? So again, you want someone to coordinate the entire sequence of events, either the surgeon or the anesthetist. Make sure that the endotracheal tube is safe, hold it in place when you're turning the head. Turn the body and the head together by 180 degrees from a trolley onto the operating table. Okay, the patient is not turned on the operating table itself. It should be on a separate trolley and then be rotated onto that to the operating table by 180 degrees. Then after that, we pull the patient up such that the head is sufficiently clear of the operating table to allow for flexion. The body should also be placed on pillows to make sure that the abdomen is going to be free and not under compression. And following that, legs should be flexed at the knee and should be elevated up to allow venous return. Now there are multiple different surgeries which can be done with this, and we have to use different positions for these. For example, the occipital transtentorial approach would also be done in a prone position, in a neutral rotation in the axial plane, and you want in the sagittal plane for that to be only mild extension and not flexion. On the other hand, supracerebellar infratentorial approach, similar idea, but here you would want a maximum amount of flexion. For this, you can even use a Concorde position. For cervical spine, again, you want a maximum amount of flexion to happen. But if you're doing a fusion surgery on the other hand, or there's some canal stenosis, you might want to keep the spine neutral. The head for cervical spine injuries, for surgeries, can be placed either on pins or horseshoe. For the rest of the spine, the head again can be placed on pins or horseshoe. Sometimes it can be placed on a donut on the OT table and turned to the side also, but make sure there's no pressure on the eyes. So this is some examples of prone positioning. So as we can see, this child over here has been kept on the OT table, the head is on the OT table, and it has been placed in this donut over here. And we have made sure there's no pressure on the eyes. This padding is provided over here to make sure that the abdomen is free. Same thing over here, and as we discussed, the feet need to be elevated up to improve venous return. Over here, we are operating on the dorsal spine, and the patient's head has been placed in a head clamp. Right, so now coming to the last position we want to discuss, a position not used as frequently anymore because of the risk of complications associated with it, but it is possible to put the patient into sitting position and do the surgery without any complications, but with a few safety techniques in situ. So now sitting position is rarely used nowadays. An absolute contraindication to a sitting position is a patent foramen ovale. If this exists, you cannot do a sitting position. So it is important that for all patients who you want to do sitting position for, a pre-op contrast echo should have been done to rule out a PFO. If it is done with appropriate techniques, it is actually a safe means of surgical access. There are some clear advantages of putting the patient into a sitting position. The gravity will drain blood away from the surgical site. You'll get a better access to the patient for the anesthetist. There will be no pressure on the eyes as compared to a prone position. The intracranial venous pressure will be low and venous bleeding will be low. Because of gravity, there will be lesser brain interaction, and the lungs will be able to better respire. But there are some really big concerns also with this position. One is there could be a venous air embolism which develops. You can also have hypotension because of reduced venous return, because the head is quite high up. Also, we are not used to operating in this position. The hands have to reach quite high up to operate here, and it can be difficult for us because you're operating anteriorly in front of you rather than down, and you're not able to rest your hand on anything. So there can be surgeon fatigue because of hand positioning also. So there are a few minimum requirements when it comes to positioning the patient in a sitting position. The arterial line which has been placed should be zeroed at the level of the tragus to make sure that you're correctly estimating cerebral perfusion pressure. So for all patients we require an arterial line. We require a precordial Doppler or a transesophageal echo to make sure we are able to immediately pick up air embolisms. If an air embolism does occur, we want a central line to make sure that we're able to aspirate it, and we want ETCO2 or capnography to be able to again pick up air embolisms. This is an example of a patient in a sitting position over here. As you can see, the head clamp is now placed anteriorly, and using the attachments we're able to attach it towards the anterior side. Now there are a lot of complications which can arise with this sitting position. As we have discussed, it can lead to hypotension, but it can more importantly cause a venous air embolism, of which there's a 25 to 50% incidence. A PFO happens usually in about 20 to 30% of the population. So the risk of any patient undergoing a sitting position to develop a paradoxical air embolism is actually 5 to 10%, which is quite significant. They can also develop tension pneumocephalus and macroglossia, and sometimes because of extreme flexion, even mid-cervical quadriplegia. Right, so that is all about the different types of positioning. I wanted to just point out this checklist for any positioning that you do. Make sure that the pressure points are always padded, that the airway and the invasive apparatus is always secure. The head end should preferably be above the level of the heart if you're operating on the head. The toes should be elevated to improve venous return. Make sure that the abdomen is not under compression for prone positioning. The cervical flexion should leave at least 2 finger breadths space between chin and manubrium. And the shoulders, arms and axilla are not under any compressive or stretch forces. Right, so that is all for today's lecture. Thank you so much for attending.